This is a courtesy announcement that the webcast is live. If you use your microphone, you will be heard on YouTube.
Good afternoon. Could I get a sound check, please?
Sounds good.
Thank you.
Thank you.
All right, ladies and gentlemen, the hour of 2 o'clock having just about arrived, I will begin by announcing that this is a somewhat unusual Health and Hospital Committee meeting that has been joined, merged, blended with our Federal Affairs Advocacy Task Force in an effort to both be a little bit more efficient and also a little more timely in terms of taking up topics. And that will obviate the meeting, the need for a meeting of the Federal Affairs Task Force, which will hopefully give everybody a little more time and opportunity to do other good works. I'm going to begin by saying we will start with item number 1, the call to order. That means I will turn to the clerk, and the clerk will call the roll and establish the presence of a quorum. Thank you.
Vice Chairperson Lee.
Present, good afternoon.
Chairperson Smidian.
Here. Thank you. Presence of a quorum having been established, that takes us to item number 2, which is public comment. Public comment is that portion of our agenda set aside for comment by members of the public on non-agendized items that are properly within the jurisdiction of this committee. Do we have any speakers, Madam Clerk? First here in the chambers. Under public comment, these are for items not on our agenda.
I have one hand on Zoom, no speakers in chambers.
All right. In the absence of anyone here in chambers, we will turn to the folks on Zoom, and following the protocol established by our board president, Supervisor Ellenberg, I will say we will let that first speaker go for 3 minutes, and then at the end of that 3 minutes, folks who are in the queue, but that will be as far as we will go. So if you are hopeful of speaking to our board on Zoom today, please get yourself in the queue before this first speaker wraps up. And our first speaker is who, please?
Our first speaker is Paul Soto. You'll have 3 minutes to speak.
Thank you very much. Go right ahead.
Good afternoon, Paul Soto from the Horseshoe. One of the things that I'd like to at least like pose a reminder is that there was about 4 months ago, there was a citizen from the east side that came in and started talking about a clinic being promised to the east side to replace East Valley because of the conditions. And the condition of that clinic is progressively deteriorating. And so I wanted to just like bring that up because we have to talk about that, because it is a racial equity issue. This is probably one of the most frequented and most vital to the maintenance of the health of citizens in that community. And so I don't know how, we're going to go about doing that, but it has to be done, because without that and getting new clinics on the west side, it's just, there's something just not quite right about that, especially considering that that clinic was promised 8 years ago. Secondly, is that we're going to have budget deficits. Now, usually when I ever hear a politician say, we're going to have to make some tough decisions, that's code word for the poor are going to get the shaft again. All these programs that assist the poor, they're going to get the shaft. And so that can't continue to be happening. I mean, it just can't, because you're not centering the principles of racial equity in budget allocations when the first programs that have to go are the ones for the east side, specifically 95116, especially that zip code. So thirdly, we have the RAND Corporation's document, and they stated clearly how many beds we would need within the THUs, within the residential treatment facilities. So with that study, I don't see a whole lot of documentation generated that speaks to that and how the county is going to amend those deficits, because there are people in the tents that can't have access to treatment because of those deficits. Thank you.
That concludes our public comment.
Thank you very much. No other speakers, just to confirm. All right. Then, without additional speakers, that takes us to item number 3 on our agenda. Item number 3 is the opportunity to approve the consent calendar and/or any changes to our committee's agenda today. And Supervisor Lee, if you're amenable, a motion to approve the consent calendar as contained in our published agenda, and to include as well items 7 and 8, where I think we have written reports that give us the information we need, would be gratefully entertained.
Yes, so moved to approve the consent calendar and adding 7 and 8 to the consent calendar as well.
All right. Motion by Lee, second by Simidian. Do we have any speakers on this item, which is item number 3, consent calendar approval?
I see no request to speak.
All right, thank you. Then let's call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Simidian?
Aye. Motion carries unanimously. Thank you very much. That takes us to a report from the Public Health Officer relating to COVID-19.
Thank you so much, Mr. Chair, Mr. Vice Chair. Just 2 categories of information I'll share on behalf of the Public Health Department today, and Dr. Sarah Redmond representing the department. First, with respect to where we are right now in this season as we come out of winter and celebrate a happy Valentine's Day, our respiratory viruses do in general appear to be coming down when we look in the wastewater, our best marker of what's happening right now and what's to come. You'll see that while we're still just above the high mark in most sewer sheds in the area, we have come down to medium in Sunnyvale. Some, last I saw, I think Gilroy may have actually tipped over today into the medium, and everything is headed in the right direction. With respect to RSV, similarly, it does appear that in all sewer sheds, we have crested our peak of the winter. Now, we are still in fairly high levels in both of these, and so it is possible that things could head back in the wrong direction. There's still a fair amount of disease out there, but we seem to have weathered the worst part of the winter surge without truly significant hits to our hospitals or unexpected levels of death and serious disease in response. I'll add one update as well, is that there were, as some of us are used to seeing with respect to flu vaccines that come out every year, and then sometime after the vaccine has rolled out, we say, did we hit the nail on the head where the right vaccine matched what was out there, what was circulating, and do we actually have evidence that this year's vaccine saved lives and kept people out of the hospital? Likewise, now that we seem to be heading into that annual pattern with COVID vaccines, we're also starting to see those data that come out after we've all been vaccinated and after COVID has started to spread through the community in that period of vaccination. How well did we do as a country? How well did this year's vaccine match what was out there circulating? We had some early data just based on how we know vaccines work and what we saw in laboratories and test tubes to show that this year's vaccine was very well matched to what was out there circulating. But as of last week, we also have data that said, yes, when we looked at actual people who got vaccinated compared to those who didn't, the people who got this year's vaccine were more likely to stay out of the hospital, avoid COVID altogether, and certainly much less likely to die of COVID or COVID complications. The second piece I want to share today more has to do with some of what I think of as playing catch up to the ground we lost in key public health activities during the pandemic. So there were many ways in which folks did not seek health care the way we normally do or had barriers to accessing them that were unusual. For many reasons, both COVID itself and the way COVID was impacting our lives and our healthcare systems. And a big one that we have some new information on just recently is tuberculosis. And while many of the times you'll hear me talk about infectious diseases in Santa Clara County, we look like our surrounding neighbors. When it comes to TB, we actually have a bit more of a unique problem here in Santa Clara County. That because of the diversity of our community, where folks have been born or grown up, and who their family members are, how we travel, we see more tuberculosis here than almost anywhere in the country. And so what we've found is that Santa Clara County saw a almost 20% increase in TB last year compared to the year prior, which was on top of a 5% increase before that. And all of this is very alarming because while TB is completely treatable, it does require a very extensive course of antibiotics with complex side effects, complex management, that is both a big burden for our care system and public health department, as well as the family members going through this very difficult treatment. And it's especially frustrating because it is preventable, both by preventing spread to somebody, and you can most of the time catch them before they are sick and recognize what's called latent disease and treat it. So this is what this trend has looked like over the past couple of years. We were seeing year over year slow, sort of wiggly, but slow improvement year over year until around the pandemic when things started to head in the wrong direction. And so the public health department is focused on doing that work of playing catch up, including a press release, social media outreach in multiple languages, media in multiple languages, including some coming out today, focused on the communities that are most impacted, to make sure folks know who is at risk for tuberculosis disease and know to connect with their doctor to get the right kind of testing and, if they need it, preventive treatment so they can avoid this potentially deadly disease. So I'll leave you there for today and very happy to take any questions.
Thank you. Supervisor Lee, I see you leaning in, sir.
Thank you, Dr. Redmond, on the update on the TB issue. The opening of our Lundy Clinic could not be more timely, shall we say, given the prevalence of our cases that you have just mentioned in our county due to our diversity, the number of immigrants that we have from all around the world. And I think I mentioned this before. My dad actually had it, but was not, I guess, completely treated, and it was through the public health department, in this case, City of Berkeley, Alameda County, that spotted it and gave him the full treatment and all that in order to finally get, that was about, 40 years ago when we first came to this country. So this is something that happens to many new migrants. So I think this is something that I'm glad we are taking this very seriously, and it needs to be treated seriously, because as much as it's treatable, it's also one of the most highly contagious disease out there. Period, isn't it?
Yes.
Right. All right. On complete separate note, one thing I did want to ask is, I believe we talked about this before, is about these COVID test kits that are expired and what to do with them. And I would just maybe ask you to explain to the audience again why they should not be thrown away and how they could be useful still.
Right. So as we've clarified before, there's a difference between the date marked on the package and whether the package still truly works. The date marked on the package indicates when the company who made it and sold it was able to prove before they put it in that box that they were going to guarantee that it still worked. Sort of like the best by date on your milk might actually be fine a day later. And there are other ways to tell whether you should still be drinking that milk, like how it smells and whether it's got chunks in it. So with respect to COVID tests, the thing you're looking for is what's called the control line. The test has a possibility to have two lines, one next to the letter C, that means the test works, and one usually next to the letter T, that means COVID or no COVID. If that test, when you run it, shows that line next to the letter C, you can assume the test still works, and whether or not you have a line next to T is the real best answer about whether you have COVID or not. So even if a test says it's expired on the box, even if it is at this point 6 months, 9 months, sometimes a year after that expiry date, we know that many of those tests will still work. So what I recommend folks do, if you've got expired tests, hang on to them. If you have the means to get unexpired tests, please do so, and there are ways to do so for free, including going to our own Better Health pharmacy to access them. But if you don't have access to them, those expired tests are still better than nothing. So if you're at a point where you need a test because you feel ill or you know you've been exposed and you're concerned, go ahead and use that expired test. If that C line does not show up, try to go get another test somewhere you can. But if that C line shows up, you can trust the result you got on the test.
And one thing I was told is there might be false negative, but there's never false positive when it comes to these tests, basically.
That is, in general, absolutely true. If you see that line next to a T, the test line is positive, you should absolutely assume that you have COVID. The only time I've seen us question that is if you're at the very tail end of your COVID infection, if you've just had it. Sometimes it stays positive for a while longer. But the COVID, there really is COVID there.
Okay. In yesterday's New York Times article, there was a published article titled "Why Do Parents Ignore CDC on COVID?" That talked about how many of the young children have not been getting the COVID boosters because of the parents. Didn't seem like this is necessary. Just want to ask you, is this something that that we see also here in our county, and what's the message here for the parents?
We're seeing it to a lesser extent here than we are in other parts of the country. And I think one of the things that New York Times article highlighted is that different countries have made different recommendations with respect to COVID vaccination in children. And in many ways, I think this is all based on the same evidence. I think the scientific world generally agrees that COVID vaccines are incredibly safe for children. On top of that, they have some benefit. And in most places, they are also affordable. But that variation in how much benefit and how affordable they are may be the best reflection about why different countries have different recommendations and why we're seeing the variation in uptake. So those other countries and critics are not wrong to say that most children who get COVID will do okay. They will come out the other side of it just fine. But some will not. Some will have very serious complications. And to some extent, some we may not know how serious those complications are because there's still so much we're learning about what we call long COVID, what happens after COVID when you've still got ongoing problems from it. And so in the United States, I think based on very solid evidence, the CDC, the ACIP, the FDA have said that for the vast majority of children out there, the benefits outweigh the risks, even knowing that the benefits may be small if you're in a situation where you can avoid getting sick, if you've got a kid with a healthy immune system, and if you get lucky to be one of those ones who doesn't have a rare complication. And part of the reason we feel so confident saying the benefits outweigh the risks is because the risks are so small, because these are such safe vaccines that have been monitored for safety to a level beyond what we've almost never been able to do by simultaneously vaccinating hundreds of millions of Americans at the same time and keeping an eye on it in the most modern way possible. We have a very good understanding of how safe these are. So while there may be individual families who want to talk to their doctor about a unique medical circumstance for their children and see if those complicated risk-benefit analyses differ for an unusual case, a child with an unusual disease history, I still feel very confident saying for the vast majority of children here in Santa Clara County, the benefits are going to far outweigh the risks, and that's why I went ahead and got my own young child vaccinated.
Right, and right now there's absolutely no shortage of this type of vaccine. So if you have children, have not gotten the latest booster yet, you can still come and make that appointment, correct?
That is correct. There should be no supply shortage. There should be no appointment shortage. And for folks who are uninsured, underinsured children, there is still the Vaccines for Children program that can help children access free vaccines.
Right, and for the families that actually do have insurance, they will need to have some type of proof of insurance to be recorded now, correct?
I'm sorry, your question is about families with insurance. Do they
Yeah,
need
for
to-
those who have insurance, I believe now they're more stringent about making sure that the insurance information is being provided to the vaccine provider. That's what I'm seeing.
Yes, in that if I were to show up at a doctor's office where I don't have insurance to see that office, they would ask me for my insurance status. And if I say I don't have insurance or my insurance doesn't cover me coming to you, I may get a bill. I should be notified before I agree to that service that I'm going to get a bill, and they can say, but your options are to go here, here, or here if you don't have the right insurance for this office.
Okay.
So what's changed is I can't just go anywhere, which was fortunately a benefit during the pandemic.
Right.
But there's somewhere for every child. And the best place to go to look for that is our own county website, covid19.seccgov.org.
COVID-19 at seccgov.org.
That's right.
Okay, very good. All right, and let's see. And last thing, going back to the TB issue, since it's such a big issue for us and many of the migrants communities is susceptible to it, just want to make sure that our messagings are going through in multilingual and different media, both on radio and TV and whatnot, correct?
That's right. Because of the county's commitment to making sure that we have multilingual staff who are expert in media communications and translation, we've been able to make sure that not only are our printed materials in languages spoken by folks most impacted by TB, but that we've been in close contact with Chinese media, Vietnamese media, Spanish language media to make sure that we're out in people's homes coming through on their television to make sure they understand their risk and how to mitigate it.
Very good. Okay, that's all the questions I have. Thank you very much,
Thank
Dr.
you.
Berman.
Thank you. Thank you for the very comprehensive report and questions, and for that reason, I have no additional questions or comments, with one exception, and that is, I just want to continue to express the view, and that's what it is, it's my view, that we are at risk of taking our foot off the gas in terms of going full speed ahead on COVID. I know we're all tired of the topic, but that doesn't mean that the problem is solved or fully resolved, and I do think we need to sort of stay on it, stay engaged, continue to do the work that's necessary, and I want to just encourage everyone to stay vigilant and take the precautions that are appropriately called for. With that exhortation, Supervisor Lee, the only requirement here is to receive the report. Can I get a motion to do so?
So moved.
I will second, and then I will turn to the clerk and say, do we have any speakers either here in chambers or on Zoom?
We have neither.
All right, then let's call the roll.
Vice Chairperson Lee, Chairperson Smidian,
Aye. Motion carries unanimously. Thank you very much, and thank you again, Doctor. That takes us to item number 5, and I believe, Mr. Lorenz, we turn to you on this item, yes?
Yes, thank you, Chair Simidian, and good afternoon. Joining me is Curtis Ohashi, our Chief Operating Officer, and Dr. Fong Nguyen, our Chief Medical Officer. As you recall, back in December, your board requested that we report back in terms of how we can improve the availability and accessibility of this important service. So I'll turn it over to them.
Thank you, and if you would reintroduce yourselves for everybody here, everybody there, and everybody on Zoom, please. Thank you. And if you would reintroduce yourself with the microphone live, that will be even better.
My name is Curtis Ohashi. I'm the Chief Operating Officer at Santa Clara Valley Medical Center.
Good afternoon. My name is Fong Nguyen. I'm the Chief Medical Officer for Santa Clara Valley Healthcare.
Great. Thank you for this report. What would you like us to know, or would you like us to start with questions? Either way.
I think we can move right to questions.
All right. Supervisor Lee, you will recall this is in part at least a response to a referral that I offered. Ms. Lorenz and Mr. Ohashi and Dr. Nguyen, you know I am sort of always kind of trying to cut to the chase and say it in the plainest of non-medical language. So what I think I'm reading and seeing here is we're going to upgrade the equipment we have. We're going to get more equipment. We're going to expand our hours. These services will be available in more places, and we're going to do more outreach. Did I get all that right? Because I'm trying to get you committed on the record in case that wasn't patently obvious.
Yes.
That's correct.
Mr. Lorenz?
That is correct.
All right. And what I think I read here as well that is also good news is that these efforts are already baked into the budget, so we don't need to contend with the fact that we have a somewhat more challenging budget situation than has been the case in recent years. Mr. Lorenz, I'll look to you.
That is correct, and clearly this is a priority for us.
All right. Could I get any or all of you to weigh in just a little bit more on timeline for, let me try it this way. I know we're never done, but if I said, when are we mostly done? When do we think this is going to be accomplished by? What would you tell us?
We have a fixed asset committee for the radiology department that looks at equipment replacement when it's at end of life. And there, you are correct, there's no really end spot. It's a continuous living document where equipment gets replaced strategically according to the input of the various stakeholders.
Mr. Ohashi, I'm just kind of in a candid mood today, so I'm going to put it to you this way. I'm termed out at the end of December. if I weren't termed out, when would I be able to stop bugging you all about this issue? Because you'd look at me and say, no, we're pretty well squared away. Let's try it that way.
Yeah, I would be happy to return with a report showing the timelines and when all the various projects start and end by modality.
So Supervisor Simitian, maybe I can expand on that a little bit, is from, I think, one of the resources that we would like to expand is to expand the digital 3D mammography to our patients, specifically those women who has dense breast tissues. So that project is already partially complete. The downtown clinic, the VHC Morgan Hill Clinic, and St. Louis Regional Hospital already have that capacity. By December of this year, we're gonna start working on, and hopefully by early 2025, we will have that capacity for all the other sites. So Tully, East Valley Clinic, Gilroy, and Milpitas. And then when the North County Clinic is up and running, there is plan to have that in place there as well.
All right. Mr. Lorenz, I see you leaning in.
I was just going to mention that the North County Clinic, which we are looking to operationalize, bring online in the summer of this year, will have this technology.
Great, thank you. All right. I think that answers my questions for the moment, although there has been a little back and forth, forgive me, Supervisor Lee, between my office and you all about the wait times for some of this technology. Your thoughts about our ability to, I'm hoping that additional equipment and additional hours will help reduce some of those wait times. Thoughts about wait times?
Yeah, the reason, in my opinion, why the wait times are variable, some longer than others by modality, is that, of course, there's widespread utilization of those different services. And when we acquired both St. Louis and O'Connor Hospital, we acquired a unique patient volume. That is coupled with a disproportionate amount of radiology infrastructure to keep up with that demand. So in addition to some of the strategies you mentioned, we're actually looking at things like additional staffing, moving people to different sites if they desire that have less of a wait time, to be able to tamp down and load level the wait times across the hospitals and the clinics.
And won't come as a surprise to you that I, of course, am mindful of the requirements under federal law and regulation now for notice on a national level, but also here in California for women with dense breast tissue. That's an issue, I know you know this, that I've been working on for more than a decade. Is that going to have any, have you given any thought to whether that'll have any impact on the demand here, or whether the fact that we already require such notice means we probably won't see any additional impact?
So Supervisor Simitian, I think with the SB 1538 that you author and has been in place for some time, our health system has been following that guidelines, and we actually have been notifying our patients of the dense breast status and the need for closer follow-up with their physicians. So the federal government, the FDA requirement that is going into effect in September of this year doesn't really have any impact to our system because we already had that in place for many years.
Do you know, if you can recall, and now I'm thinking sort of nationally, what the impact will be, if any, whether there was in fact stepped up demand for these additional modalities when we put the new notice requirement in place, gosh, a decade ago now? Does anyone?
Supervisor, I don't think we have data that we can point to. I think we do know that when patients are informed of the possibility that a screening modality might have lower sensitivity if it's not able to pick things up as much, people tend to have closer follow-up potentially. Therefore, I guess we can infer that there will be women who might have skipped out a mammogram would return for a mammogram when it's due. But I'm not aware of any national statistic that we can refer to.
All right. Well, I'll just indicate for you and for the rest of the team, if at some point there's any indication of noticeable or quantifiable demand impact, I'd be curious to hear it here in the committee. Forgive me, I should lean in here. When the legislation was being debated, there was a little back and, well, more than a little back and forth that went something like this. The legislation I carried at the time and that advocates supported was designed to require the notice. There was some pushback from some folks in the medical community that would drive demand up. And my reaction was, well, that might be a good thing because then people would be accessing modalities that really would get the job done for them. And the reaction to that from opponents was, but if that is too great an increase in demand, then that would overburden the system and involve additional costs, which in their view were not necessarily appropriate. So I'm trying to, what I'm trying to ask here is, you know, did we find a sweet spot? Have we gotten over the course of a decade to a place where people now understand there are these other modalities and they can have the conversation and access them when appropriate and called for? Have we gotten to a place where there's an overuse, an excess in demand? You know, this is, as I say, this is a matter that's about to play out on the national stage. We're, you know, here in California, we've sort of found whatever level of equilibrium we're going to find, I think, after a decade. But thank you. All right, so equipment upgrades, more equipment, longer hours, more places, outreach, and I neglected the first time to say an additional staff availability based on not only training, but some cross-training as well, that's referenced in your document. Supervisor Lee, to you. And then we'll see if there are questions, or excuse me, comments.
No, actually, I don't have any questions on this item. Thank you.
Thank you. Then let me look to the clerk. Do we have speakers either here in chambers or on Zoom?
None in chambers, one in Zoom.
Let's call on that speaker who is on Zoom. And pursuant to the rules of the board and the committee, we'll authorize up to 2 minutes for comment. Welcome.
Apologies, my computer just turned off. There is a speaker on Zoom. If our staff in the back could unmute that speaker and allow 2 minutes, please.
And if that speaker can hear the sound of my voice, please feel free to go right ahead and share your thoughts with us for up to 2 minutes.
Yes, hi, my name is Joe Cavaro. I'm with the Hospital Council, and just would like to thank you, Supervisor Smidian, for bringing this awareness to and the expansion of breast cancer screening, and appreciate your leadership on this. And getting more people screened is very important in our community. Thank you.
Thank you. Madam Clerk, anybody else?
To my knowledge, that concludes public comment.
All right.
Camille has confirmed. Thank you.
Mr. Lorenz, I'm going to take it from your comments and those that have been shared that no other action is necessary at this point, that we can simply receive the report. But I am interested in, Mr. Hashi, thank you for the offer for the timeline. When might it be a good time to come back and share with us what you all are doing? September, that sort of gives us, you know, the better part of the year, but it gives me time before I have to vacate the premises, so.
September would be fine.
All right, then let's ask for a report back on September in addition to a timeline report on what has happened by that date and what it remains to be what remains to happen, excuse me, and what the timeline for the remaining work would look like in September. That'd be great. Supervisor Lee, can I get a motion to that effect? Motion to receive the report and to request a report back on that time. And I will second, and let's call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Thank you all very much. Please stay on it. I know you will. That takes us to item number 6, which is to receive the report from the Santa Clara Family Health Plan. I see a gaggle of talented people making their way forward. Welcome to you all, and who would like to begin? And as each of you speaks, if you could introduce yourself, please, give us your name, your title, and may seem a little awkward, but if you could do that every time you speak, just, give us your name and title again for folks who are listening out there in Zoom land. I've heard that it helps them keep track of who's sharing information today.
Thank you so much, and I think my microphone is working. Good afternoon, Chair Simidian and Vice Chair Lee. I'm Christine Tomkala, the CEO of Santa Clara Family Health Plan, and I'll be our primary speaker today, but I do have my colleagues with me here today, and I'm happy to introduce them, or is it preferred that they do it in their own voice?
Let them do it in their own voice when the moment arrives.
All right, will do. All right, so thank you for the opportunity to provide some updates to the committee this afternoon. So starting as introduction, just as a reminder to folks, Santa Clara Family Health Plan is a public agency that was established by the Board of Supervisors back in 1997, so over 25 years now. And we operate 2 lines of business, one strictly for Medi-Cal members, and another for Medi-Cal members who choose to have us also handle their Medicare benefits. So as you know, we're in a 2-plan county, but we now have 3 plans in our county. So in addition to ourselves, we have Anthem as the commercial plan and Kaiser. And as you may recall, Kaiser had been under the membership for our plan. They were subcontracted with us, but they now have a direct contract for Medi-Cal with the state, so they are now the 3rd plan in our county effective January of this year. So all of the members that were assigned to a Kaiser primary care physician in our plan were automatically transitioned to Kaiser, and Kaiser will continue to enroll, certain Medi-Cal members in a sense as they have done in the past. And as you know, that we have our 13-member governing board that the Board of Supervisors appoints, and so thank you for that. In terms of our enrollment, as you know, with the COVID pandemic, the federal government had issued an order prohibiting states from disenrolling anyone from Medicaid, and so our membership continued to increase to over 326,000 Medi-Cal members by June of 2023. And at that point, redeterminations were reinstated, and so we started to see disenrollment starting in July of 2023. And we expect those disenrollments will continue for over a year because the state has not been able to keep up with the volume of disenrollments, and so they've indicated that they expect them to continue processing them through October. So you can see that effect. If you look at this chart, you can also see there's the dip where you can see the note for Kaiser transition that I just mentioned. We, in fact, lost about 40,000 members to Kaiser, but then the little uptick that you see is reflective of our newly eligible populations. So these are the adult members who may not be documented, and so now there are no longer any gaps in Medi-Cal eligibility for folks because they are not documented. So we've seen a little bit of an uptick, and we expect that we'll continue to see some additional members in this bucket. But overall, our membership will continue decreasing because of redeterminations. All right. Next slide. Just talking a little bit about that Medi-Cal renewal. Trying to work with our members who are eligible for continued coverage has been a top priority for us to make sure that they are sensitive to the renewal process and are able to complete the necessary paperwork. And we've been working in collaboration with the county and other local groups to get the word out to members about the redetermination process. And so this is reflecting some of the activities that have been undertaken. It's been challenging in looking at the data to understand exactly sort of all the impacts and all the complexities. And I understand the social services data, I believe, is coming up on your agenda today, so you'll hear more about it then. But one key thing to know is, as a member comes up for redetermination, if they haven't figured out their paperwork and the data is not available at the time of their redetermination, they have a 90-day grace period to complete any paperwork. So the state attempts to reach out to that member, and the member is not discontinued until that 90 days passes. And then if they haven't continued or have not been able to complete their paperwork, then they would be discontinued. And if they're still eligible, they'd have to reapply for Medi-Cal. It appears from the data that we have seen that ultimate discontinuation rate is similar to pre-COVID, so we think the outreach efforts are working, but again, it's challenging to get the specific data. Moving on to enhanced care management, I understand that this committee was interested in CalAIM and its ECM benefit that launched in 2022. And so in terms of an update for you, you can see that it's a phased implementation with 8 different populations of focus. And just to refresh your memory, ECM is a type of intensive case management for the most high-need members enrolled in our plan. And the 2 new populations of focus that we launched in January of this year are the pregnant and postpartum members subject to racial health disparities and individuals transitioning from incarceration. And so we are now serving all the populations listed on this chart. As we move on to community supports, and we may have a technical difficulty here. You may recall that there were 14 community supports, which is another CalAIM initiative that was launched in 2022. And these are meant to be
Ms. Tomkala, excuse the interruption.
Yes.
If we have a technical difficulty, shall we pause for a moment and see if we can get the system righted?
It looks like the screen share stopped. Tyler, are you able to get that back up?
I am, but I lost access to the document for some reason, so I'm working to get it back. Sorry.
Yes, Camille, can you share the backup?
Tell you what we're going to do. We're going to take a 2-minute break, and we'll see if you can get your technology back up. If not, we'll just go forward without it. But
Thank
take
you.
2 minutes without us looking down your corridor here. Thank you.
Thank you.
Stand in recess for 2 minutes. Thank you.
Now we have it up. I wiggled everything and I swapped cords with this one so that because this one said it's charging. Oh, see now it's going. It's like
I just changed.
Oh, is that the new one?
Changed them out, but I'm not going to see the whole
Okay.
charging thing.
Good.
Because that happened to me the other night, and I butzed with the thing, and butzed with the wall, and then it popped on.
Okay. Well, I'm in the
All right. We will call the meeting back to order. The recess is completed, and we'll see whether or not we are, and according to my screen, we're ready to proceed. So thank you very much.
All right.
Ms. Clara, go right ahead.
Thank you for the break. So when we left off, we were chatting about community supports, which is another CalAIM initiative that was launched in 2022 for Medi-Cal. And these supports are meant to be cost-effective alternatives to more traditional and more costly services like hospital or long-term care admissions. And so, as you can see, most of these supports are geared toward keeping people housed and out of hospitals and nursing homes. And we currently are offering 13 out of the 14 state-approved community supports, and we'll be launching that final one, the short-term post-hospitalization housing, here in a few months, and then we will have all 14 available. Next, I just wanted to touch briefly on the Housing and Homelessness Incentive Program, otherwise known as HHIP. And because it's a collaboration with the county, I wanted to share a bit about our work. And this is a voluntary program that we have opted to participate in. So HHIP leverages one-time federal funding to incentivize plans like ours to increase partnerships and capacity to assist our members with housing needs and reduce homelessness. And so we are working jointly with Anthem and the Homelessness Continuum of Care, including the county, and it gives us the opportunity to draw down up to $60 million in funds if we achieve certain state-imposed metrics. So really our role is as a convener and to develop some partnerships that we hope will be ongoing. So we consider many of these initiatives to be win-wins for our respective agencies and the people we serve. And the investment in homelessness prevention and expanded shelter and temporary housing will reduce homelessness while easing strain on existing county resources. The Medi-Cal hub billing model will also increase the county's capacity to provide the ECM and community supports that we've just been discussing. So speaking in terms of housing-related win-wins, we wanted to thank you for the committee members who voted to approve our agreement with the county to reserve 46 permanent supportive housing units at Kiefer Senior Apartments for our Medi-Cal members who are without housing to transition from skilled nursing facilities. And it also will help reduce homelessness and improve social determinants for our Medi-Cal members and reduce costs for our respective organizations. Next up, we have Student Behavioral Health Initiative Program, which is another collaboration with the county and is our collective work. The state is interested in seeing schools be better able to meet the behavioral health care needs of their students at the school since they spend most of their days there. And similar to HHIP, SBHIP uses one-time state funds to incentivize the Medi-Cal managed care plans to increase partnerships with counties and schools to improve behavioral health for the students. So we're working jointly with Anthem, the county, and the County Office of Education, and we have developed plans to create wellness centers in 6 school districts to increase Medi-Cal billing capacity and referral processes between schools and managed care plans, expand the campus-based behavioral health workforce, and invest in IT infrastructure that will facilitate coordination and billing of services between managed care plans, the county, and our schools. As you may recall, when I presented a year ago, the VHP and VMC quality scores as providers of service to our members. We are now updating those for 2022, which is the most recent finalized year metric that we have. And when we're referring to quality in this context, it's how we measure and report to the state the value of services provided to our members. So the state requires us to track a large set of metrics, but what we're displaying today are a subset of those that are held to a minimum performance level, or MPL. And the state determines the measures that all the plans are to report on, and the MPL is currently set at the 50th percentile nationally for each metric. So what you see here are the 2022 results for SEFHP members served by both VHP and VMC, which is part of VHP's network, so that impacts the VHP scores. and what's the overall effect. So as a result of our collaboration, I'm pleased to report that many of the scores have improved, and most now are exceeding the MPL. Mind you, the MPL is a metric that continues to increase because that benchmark is the national average, and all the health plans are working to increase it. So we need to continue our work to increase our actual performance on these metrics just to stay level with MPL going forward. And I also think we all would like to ultimately outperform the national average, both for our members as much as anything. So while our metrics are still hovering around MPL, we hope we can continue to work collaboratively to get those numbers increasingly increased. The next slide is also the remainder of the measures that are held to MPL, but this one is a little different. You don't see the colors on it because these are administrative only measures or data. And so these are hybrid measures that include some chart review in the final scores for our health plan. And so some medical records are randomly reviewed, and then that additional data is included in addition to this administrative data, and it changes the scores. So we don't really have a great benchmark. You can't really look at these scores compared to the MPL right now. So we're rather sharing a column of how our non-VHP providers are performing on these metrics as a point of comparison. And so while we've continued to see improvement over the 2021 rates, a number of areas are running close to and above the non-VHP average, but there are a couple with opportunity for improvement. In particular, I'd like to point out the cervical cancer screening and immunizations for adolescents, where there appears to be some opportunity. And I also would like to encourage the committee to continue to prioritize quality improvement for our Medi-Cal members and routinely review the data for VMC and VHP on these metrics. And since our Medi-Cal members account for 3 out of 4 VHP members and half of the Santa Clara Valley healthcare outpatient visits and a third of their inpatient days, I think that it's a good use of the committee's attention. So the next slide is just a reminder that we have our Blanca Alvarado Community Resource Center in East San Jose, and it's been up and running now for a little bit more than 2 years, and we continue to introduce new programming and opportunities to increase health and wellness in East San Jose. And we want to thank you for your support and frequent attendance. I know I've seen some of you there myself, and I appreciate your staff coming to our community events as well. And then specifically with respect to how we develop the programming at the CRC, we have a framework. We believe that the initial success of our CRC was developing this hub for community health activity, and it encouraged us to consider whether it could be replicated in other areas with high numbers of Medi-Cal members. And so to do this thoughtfully and methodically, we tried to codify the process we used to develop our Blanca Alvarado CRC, including lessons learned, into a framework we could use to develop future CRCs. So this framework's available on our website, and I'm happy to share that we are starting to do some of this work in South County in the Gilroy area, where there's a high concentration of our members. And we are implementing a service hub this month in Gilroy out of the Neon Exchange, which you may be familiar with, where we can provide some one-on-one enrollment assistance. And we're using this framework to continue to explore needs for an additional community presence in that area. And then lastly, there's just a slide here on our health equity agenda, which is a project we've been working on for a few years now that's about to come to fruition. A group of CBOs began meeting in early 2021 in an effort that came to be called the Health Equity Agenda. And this is a project to increase health equity by identifying and responding to racial health disparities in our community. And it includes partial funding and participation by the county. And so we're very grateful for the participation and involvement of the Public Health Department. So we've now completed our research, and we have identified a list of metrics to target, and we expect to begin publicly releasing information soon with our related proposals to improve outcomes in the near term. So please stay tuned for that. And that concludes my presentation, and we'd be happy to entertain questions.
Thank you. Thank you. This one won't surprise you. Could we go back to page 9, please? Thank you. Oh,
One more.
we overshot. There we are. And of course, in that sea of green, which I want to acknowledge and say good on us. The one red number there, of course, is for child and adolescent well care visits. Could you just tell us a little bit about what are those? Why are they important? And why is that the one place in your estimation that the number is red rather than green?
Hi, I'm Ria Paul. I'm the CMO of...
And let's try one more time on the microphone.
Okay. Hi, I'm Ria Paul. I'm the CMO of Santa Clara Family Health Plan, and I can take that question. So the child and adolescent well care visits, they are like interval visits at various age groups for these group of members, and that's where we check the developmental screening, how the child is progressing, and also focus on the various social aspects of care. And so this is something that we partner with all our medical groups, Valley Health and Hospital Systems, so that they are kind of bringing all our members in to have this periodic checks. During COVID, what we saw that this was kind of a little bit of on the back burner, mostly for parents because they didn't want to bring their kids to the health systems, and so there was a certain drop, but we are picking up, and these are the perfect opportunity also to give immunizations for these patients in a timely manner. So that's why, all in all, from the social, physical, and wellness aspect, these visits are very important.
Thank you very much. Supervisor Lee, any comments or questions?
Yes, do have a couple of follow-ups. So first of all, thank you so much for the very good presentation on your slides to show the amount of work that you have done. And this is a really amazing amount of work that has happened in the past couple of years. So really thank you for the hard work that you and your team has been able to put together. When it comes to talking about access, right, the access points for the enhanced care management and also the community support services, how do you envision of increasing these access points to both of these populations?
And Ria, would you like to address that as well?
So basically, what we are looking at, sort of revolutionizing the access approach, because we know there is limited access for every health system, like medical group for Valley Health and Hospital System, and also FQHCs. So we are encouraging them to see how can they also provide not only in-person care, but also virtual care. And that's what we are advocating that, and how also various touch points can happen not only with the physician, but also with the care team, like a medical assistant or a care coordinator reaching out to the member to check on them to see how they're doing. Because not everybody needs to see a physician or an in-person or a virtual visit with a physician, but just a connection with the care team provider, like how they're doing and so forth. So that's how we are looking at various aspects, in-person, virtual, and various elements of the care team, how they can interact with the member.
So when you say virtual, you're talking about the type of telehealth.
Telehealth,
type
correct.
Of, you could do it with your phone or
Exactly,
right,
phone,
and,
video visits, anything, like a connection, like a touch
right.
point.
And certainly scheduling those would be far easier. So I think they
Far
could,
easier,
far
yeah.
easier. So they could get access to the provider much quicker than the
Exactly.
normal wait time. Right?
Yeah.
Good. What would you say is the best way to improve the outreach as well on making sure people understand how to access these services?
So what we are doing now, we are working very closely with all the clinics to make sure that they have the sufficient resources to make this outreach. And if there is any way that the helpline can help. So there are multiple ways we are doing outreaches to our members, not only through the regular newsletters, faxes, and so forth, or we can do text yet, but that's what we are looking at. How can we enhance all of these communications to our members in various ways? And definitely assisting the physician groups, how they can reach out to their members.
All right. Going back to the early slides, we looked at some of the areas that, even though it's not necessarily red, but I mean, certainly it's below the requirements. I think it was, yeah, that's the screen would be not that one. I think it's the one.
Supervisor, I think you're
Yes,
speaking
correct.
away from your microphone, sir.
Thank you. Yes, that's so you can hear me better. Thank you for the reminder. So, for example, if you look at diabetes, for example, right? So that's the one that is lower, as well as cervical cancer, and you mentioned the immunizations as well. Let's go through the diabetes HbA1c area. How would you improve that one?
Yeah.
Yes.
That's a very good question. That's what we are honing down on, because diabetes care, as we all know, if we are not addressing it, there is so much downstream effects from that. And so that is where we are focusing. We have developed 3 programs together in conjunction with our pharmacy team, and that pharmacy team, together with our outreach staff, is reaching out to all our identified diabetic members and also to the provider clinics. And also we are working closely with VHP2 on how we can enroll all these members who have diabetes, who are uncontrolled, in these programs and provide them with necessary resources.
Mm-hmm.
For example, how can we give them like continuous glucose monitoring? So this is
Exactly.
something, that people who have high blood sugars, they really benefit from that. And so now that's what we are trying to do. How can we provide them with that? And also there are a lot of new drugs on the market for diabetes. How can we help them get on those medications that will help bring down not only their blood sugars, but also improve provide protection to their kidneys, heart, and so forth. So that's what we are trying from the helpline side. How can we make our pharmacy benefit much more richer and more convenient for our members?
Yeah, so a couple months ago, I attended a conference and was seeing some of the products available for constant monitoring. I think Abbott Labs has one where you could actually wear, basically,
Yes.
constantly, and it'll be able to see in your phone.
Exactly.
Right? An app, right, to monitor. And of course, once people know their A1C status and the glucose level, I think that certainly would help them to control it. And me, myself, being at the pre-diabetes level, become very interested in this program. So I certainly want to make sure that these gets publicized to all the different communities in language as well.
Absolutely.
And
That's what we are hoping to do in various languages.
And those are all covered by our plan, right? So
Yes.
the individuals really have very low out-of-pocket costs to enroll in those things, right? Yeah, okay. How about cervical cancer screening?
Well, cervical cancer, there is some cultural issue around cervical cancer, and that's what we are trying to work towards. How can we make our members more knowledgeable in this area, and how to provide care in a more culturally responsive way so that they are more open to doing this. And it is a work in progress. And we definitely have improved than before, but again, there is much work to be done here.
So there's stigma, cultural stigma is part of the problem in terms of getting the word out to folks how important this is.
We can get the word out. It's just that many folks don't want to do it. In some racial ethnic groups, they don't want to do a pap smear. So that's where we are trying to break that down, that this is more from the health perspective, what can happen in the future, cervical cancer and so forth. So we are trying to deliver that message.
Right. So I think it's important to have the educational piece.
Educational
right,
piece,
to make
correct.
it, I won't call it dumb it down, it's not that, I'm just trying to make sure that it's really understandable for individuals, especially in different languages,
Exactly.
to understand why this is absolutely a lifesaver, for
Exactly.
example, in the future. And you talked about the immunization part, so thank you very much. I think that's all the questions I have for today. Thank you very much.
Thank you.
None for me, other than the one I already asked, and thank you for the helpful answer. Any other comments or questions from folks here today? Yes.
I just wanted to verify, I think the diabetes A1C measure is an inverted measure, so lower is better, is that right? Just wanted to be
Correct,
right, that
correct.
clarification,
You're-
so that
you're
that
right.
measure doesn't look as
Yes.
bad as I think.
No.
should be
Yeah,
thinking.
you're right.
Could you explain that maybe, just so we have it for the record?
Oh, okay.
Thank you.
So basically, whenever we want lower hemoglobin A1C, so higher hemoglobin A1C not good, the lower number is actually better. So means usually we want these probably in the 20% or so forth, but here we are still kind of higher up there and things like that. So, but we are getting there, so.
So a good would be 20%, not 80% or 90%.
No,
right?
no,
So
yes.
Just wanted to make that clear.
Yes,
Thank you.
thank you.
All right, thank you very much. Do we have speakers on this item? Here in chambers, let's begin.
I have none in chambers. I believe I have 2 in Zoom.
All right, let's hear from the 2 folks on Zoom, and if anyone else would like to join us and comment on Zoom, we would ask that they raise their virtual hand before the first speaker has concluded their remarks. Thank you very much.
Our first speaker is Ken Horowitz.
Thank you. Welcome, Mr. Horowitz. As I think you know, you have up to 2 minutes. Go right ahead.
Yes, thank you. This is Dr. Ken Horowitz from the Health Advisory Commission. And as you know, our commission looks at healthcare. And one thing that very concerning to us, our commission, is dental care. And unfortunately, there's no measurements on these slides about dental care. But according to the Public Health Department, only 22% of Medicare patients had an annual visit, and 19% had a preventive visit. Now, Family Health Plan is responsible for almost over 75% of our Medi-Cal recipients, and they basically are not doing their job providing dental care. What they have done is carved out dental care to Smile, California. This is unlike San Mateo Health Plan, who has carved in dental care. So I just wanted to point out that this is an area of healthcare that's being overlooked by Family Health Plan. Now, my last point is you, the Board of Supervisors, appoint the Health Authority Board, which is the board of directors for the Family Health Plan, 13 positions. But unfortunately, you appoint them, but they don't have to report to you. And so I would encourage you to look at the board of directors. They need to be more diverse. And I'd like to see a dentist on the board of directors, because then we would be ensuring that at least dental coverage would be foremost of concern to Family Health Plan. So I appreciate you allowing me to express my point of view, and a referral is going to be coming from the Health Advisory Commission to you regarding this particular concern. Thank you.
Thank you. I will let the folks from the health plan comment after we've heard from all the speakers, and that'll give you a moment or two to pull thoughts together and also make sure we only turn to you once. To our next speaker, please.
Our next speaker is Paul Soto. You'll have 2 minutes. Please go ahead.
Yes, Paul Soto from the Horseshoe. Thank you, Dr. Horowitz, for bringing up those particular issues. They sound like they're racial equity issues. You know, it's frustrating for me as a member of the Chicano community to know, without even being given the information, who is going, what population is going to be the one that is not receiving that kind of treatment in terms of dental. And I shouldn't be able to predict that. And the fact that I can means that we haven't institutionalized racial equity in terms of a policy, not some guiding principle, but an actual policy that institutionalizes that so that the budgets, when they come in, that they go directly to the populations that have been historically deprived of resources to maintain their health. So thank you, Dr. Horowitz, for that. Secondly is Colleen. I didn't hear anything about Colleen, and maybe you would have skimmed over it or something, but what Colleen was designed to do is that we have to make treatment, drug treatment, accessible, immediately accessible. And it has to be localized. It has to be near the populations. They have to have it accessible within their community. So I didn't hear like a whole lot on that. And Mayor Mahan is literally, he's delusional. He really believes that he's just gonna go around the city just locking people up. And there's this infrastructure ready to accommodate them after they're transferred from the jail to these facilities. The facilities don't exist. They do not exist. So what's gonna happen to those populations when they get locked up?
That concludes public comment.
Thank you very much. Let me turn back to the folks from the health plan and see if they'd like to give us any additional information.
Thank you. And I'm Tyler Haskell, Vice President of Government Relations and Compliance. I just wanted to point out, in response to the first comment, just to clarify for the committee and the public, that dental services are not part of the managed care Medi-Cal set of services and benefits that we offer. Dental services for Medi-Cal members are provided under the Medi-Cal fee-for-service program. So that's why it's not included in our quality metrics, because the state doesn't require to track us and report it, because we are not contracted with the state to offer it and provide it.
Having heard that, I think part of the point that was being made by the speaker was that San Mateo County takes a somewhat different approach to providing these services or making these services available. Could you clarify a little bit the difference in approach?
San Mateo County has a pilot program with the state. I believe they're the only managed care Medi-Cal plan in the state that has such a program. It's a pilot program where they have dental services carved in their plan in that one county in the state with that one plan. So they're testing the model. The state's testing the model with San Mateo, but it's not available at the moment in other counties in the managed care program. And that wasn't a decision that we made in our plan or in our county. That's long been the case in the state.
Any idea when that pilot will be concluded and hopefully provide some insight into the efficacy of the program or not, as the case may be?
I don't know.
My recollection is the pilot was a 6-year pilot, and I think we're about 2 years in right now. Now, it's possible that the state could see favorable results and decide to take action sooner, but the original proposal was a 6-year pilot program.
Ms. Hanson, sorry to put you on the spot. If we were to ask for an off-agenda report on the status of that pilot and what lessons learned might be available now, understanding that the pilot is apparently far from complete, who would we ask to provide that off-agenda report?
I would want to give a little bit of thought to that after looking into the program itself, but I'm happy to, if that's a request for information to administration, to figure out who is the most appropriate person within county administration to respond, and also perhaps partner with Family Health Plan on bringing forward a response.
Thank you. Well, when we get to the motion to receive the plan, which I expect we will in a moment or two, I'm going to ask the maker to incorporate a request for an off-agenda report sometime before the end of this fiscal year. And of course, if it's an off-agenda report, it will be a public document and available not only to our committee, but the board and any member of the public, including folks at in our committee system who might be interested in looking at the possibilities. All right. Thank you very much. I have no further questions. Supervisor Lee, any other comments or questions?
None from me. Thank you very much.
Thank you.
Could we get a motion to receive the report with direction to provide a report back on the pilot that's underway in San Mateo County as to dental services, and that ask that report back be made available prior to the end of the fiscal year?
So moved.
Motion by Lee, second by Simidian. We have taken public comment on this item. We will say thank you to the folks at the Family Health Plan. Call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Simidian?
Aye. Motion carries unanimously. Thank you very much. And Madam Clerk, I'm going to ask you to keep me accurate here. Items 7 and 8 were both placed on the consent calendar, I believe, which I think means we are ready for item number 9 at this point. And we return to a discussion about diabetes, which we began a little bit earlier in a broader context. Who's going to preside? I see 2 lights on, so who begins?
Thank you, Chair Simidian. Joining us is Dr. Patricia Salmon. I'll turn it over to her.
Doctor, would you reintroduce yourself? I didn't quite get your last name.
Hi, this is Dr. Patricia Salmon. I'm the Chief of the Division of Endocrinology at Santa Clara Valley Medical Center.
Thank you very much. What would you like us to know?
I believe you have the report
We do.
before you, so I'm here to help answer any questions you may have.
All right, and before we go there, let me turn back to our Public Health Director and see what comments, if any, you would like to offer to start the conversation off.
No comments, just to also note that we have the report in front of you that lays out both the Santa Clara Valley Healthcare's role in caring for folks with diabetes and prediabetes, as well as the Public Health Department's purview, focused on trying to prevent both diabetes and prediabetes and create environments where folks with these diseases are successful in their health goals. So happy to answer any counterparts to Dr. Salmon's questions with respect to keeping folks from needing the services of SCVH.
Thank you both. Supervisor Lee, I know this was an issue of particular interest to you. Why don't I defer to you then with comments or questions?
Well, Doc, welcome, Doc. One question we have regarding the monitoring, or they call it the continuous glucose monitoring. How can we make that more widely available to our patients? And what type of cost are we talking about if they don't have insurance coverage or with Medi-Cal coverage?
So continuous glucose monitors are devices that measure the blood sugar level every minute of the day. So they're really only indicated predominantly for patients who use insulin to treat their diabetes. Those who are using oral or other agents typically do not need these types of devices. As we've discussed earlier in this meeting, we know that Medi-Cal has expanded its coverage to undocumented individuals, and Medi-Cal does now cover continuous glucose monitors for appropriate patients, and typically there's no out-of-pocket cost for our patients with Medi-Cal. Medicare also covers these devices, as do most commercial plans. So for the small amount of patients who are uninsured, the out-of-pocket cost could be quite high depending on the brand of device. Some of the manufacturers do have sort of coupon or discount programs where they might be able to drop the cost to $75 to $100 a month, but some of the fancier devices, so to speak, may cost patients, $1,000 or $2,000 a year, several hundred a month. But patients without insurance who have the appropriate need would likely be covered under the county's PCAP or HAP programs to get a discount. And also, of course, we have our MedAssist program, which I think supervisors have been involved with, and that includes patients with diabetes.
So when you say appropriate, you're saying, am I understanding that only those who are taking insulins will be eligible? Or could it be folks who are you mentioned the oral medications, or how about those who are prediabetes?
Yeah, so typically it's not necessary for patients with who are just taking oral medications to use these continuous glucose monitors. So I think most insurance plans follow CMS's coverage guidelines, and CMS does require patients to use 1 or more injections of insulin per day, or have a history of low blood sugars, which can also be quite dangerous. So there are some exceptions to the insulin rule, but on the whole, if a patient is just taking 1 oral medication or perhaps managing their diabetes through diet and exercise, they don't really need to have that moment-to-moment blood glucose information.
Okay, thank you. On another subject regarding the VHC having the diabetic retinopathy screening cameras being installed, When would those 10 clinics have those cameras installed, and how much are those units costing?
I'm sorry, I'm having trouble hearing
Oh,
you.
I'm sorry, let me try again. So for the 10 VHC clinics having the diabetic retinopathy screening cameras being installed, when are they getting installed and how much do they cost?
So they're currently in the process of being rolled out to the primary care clinics. Ideally, they'll be in place around April to June, depending on some policies getting passed. And they'll really provide a great service for our patients, one-stop shopping, so that they can have their screening done while they're visiting their primary care provider. The cost is several $1,000s per machine, but of course, this is a billable service because it is a recommended screening test for all patients with diabetes.
Okay, so I guess I'm trying to see if we could look at potentially requesting our administration to come back to HXC in a couple of months with the cost and timeline associated with each of the 6 key activities that could be implemented over the next 4 years, pending funding, of course. And I want to study these costs and assess what is feasible for county to potentially move on to these ideas. Is that doable?
Sure, we're happy to bring back some further assessment on that. But we might, I'm just looking at Dr. Salmon and wondering if she might have a clarifying question to make sure what we're bringing back is what you're looking for.
Yes, thank you. Supervisor Lee, I was wondering if we could clarify the 6 points. Are you referring to the section on diabetes prevention outreach from the public health portion of the report?
Yes, that's correct.
Okay.
Yeah, that's right. That's
Thank
what
you.
we're talking about. Great. Thank you.
Deferred it.
All right, and that's all the questions I have. Thank you, Chair.
Thank you. None from me. Let's check on public speakers here in chambers.
I have no requests in chambers or on Zoom.
All right, then a motion to receive the report after saying thank you would be well advised.
So moved.
Motion by Lee, second by Semidian. Call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Semidian.
Aye. Carries
you.
unanimously. Thank you very much. And that takes us to item number 10. Thank you again, Dr. Salmon. And item number 10, Mr. Barry, do we hear from you today, sir?
Yes, sir.
Go to it.
Thank you. Good afternoon. David Barry, Chief of Planning, Facilities and Fleet. I appreciate the opportunity to provide you with an update on the progress of the county's efforts to establish a new De Anza West Valley Clinic on the De Anza College campus. As of now, several key developments have taken place. Firstly, I'm pleased to inform you that the geotechnical report has been successfully completed and is currently under review, but initial indications suggest that the soil conditions are favorable, which is certainly a positive aspect for the project. The estimated budget for the construction of the clinic and garage is currently in the process of being finalized. We are diligently working on this and will provide you with all the details along with the rest of the feasibility study. A crucial milestone to mark on your calendars is the presentation of the feasibility study to the full board scheduled for February 27th. This presentation will encompass the various building massing options that were outlined in the written report to the committee. That essentially wraps up my report on the current progress. I'm now open to addressing any questions or concerns that the committee may have.
Thank you. Supervisor Lee, and then I'll have some questions. All right, let me ask, whenever you say the word garage, my ears perk up. What's the current thinking about parking on the site and the needs for an additional structure or not?
Well, our feasibility study includes a parking structure if it's deemed necessary, and that's to be determined with our conversations with De Anza College.
Did I understand correctly that on the 27th you expect to bring budget as well, or rough budget figures?
Correct.
Will the garage be a separate component?
Yes.
All right. I want to be very clear about this, and I want to put the team on notice prior to the meeting on the 27th, so there are no surprises at the meeting on the 27th, either for the county team, folks at the college, or on our board. I have been expressing concern since the beginning of this conversation about the sort of operating assumption, the built-in expectation that we need more parking. I have yet to be convinced of that. And I don't want this project freighted with unnecessary additional cost for parking if the parking is not truly needed. I understand that, you know, we have to have this conversation, but I just feel like we're not wrestling that issue to the ground. So I want to be very clear that the conversation on the 27th should be a conversation we have with an easy ability to parse what the cost of parking is on the project, and with no expectation that that is a given. Now, Mr. Barry, forgive me, I'm sorry, you drew the short straw, you had to show up today. Was I clear just now?
Yes, sir.
Is that something that I can reasonably expect on the 27th?
Yes, and like I said, the cost estimate does separate the parking garage, and this is conceived of as a standalone building and a separate parking garage, so they do not necessarily need to go hand in hand.
Ms. Hanson, can we ask that you and the county executive exert whatever influence is necessary to make sure we have information that comes to us in just that way, so we can have a real conversation about what. I don't want the number going out that the facility costs X, when in fact the facility doesn't cost X. It costs something appreciably less than that if we would wrestle these parking issues to the ground. Is that doable for the 27th?
That's doable, and let me just make sure I understand what you're asking for, which is based on what you're asking and what Mr. Berry just shared. It sounds like they have separate cost estimates for the facility and what would be a parking structure if needed, so that those would come back separately. It also sounds like, Mr. Berry, I don't want to put words in your mouth, that there will be some explanation of whether and to what extent that parking structure is considered needed or not. Is that correct?
Correct.
Okay.
Or we can provide the county's opinion about that. I can't speak for De Anza.
How long has this conversation been going on, Mr. Barry?
Since the feasibility study began.
A long time. Could we please ask the folks at the college what their current thinking is?
Certainly.
Thank you. And be prepared, please, to answer that question at the meeting on the 27th. This is a long time in the making, and we've got data on the use or lack of use for the various parking that's there. I know the site well. As a kid, I actually lived a mile or two away from the site for a while, and well, I think you can tell from the fact that I keep pressing on the issue and the tone of my voice, I'm more than frustrated. When we get a number for the cost of the project on the 27th, would like that number to reflect the cost of the project, not the garage. And if we do hear the price of the garage, which I expect we will, because that's information that we need to have, I would like to make sure again that it is very clear that it is separate. And if after this conversation we can't get that level of clarity at our meeting on the 27th, I think you can expect that I'll dig in even more. Okay?
Thank you.
Thank you. People need the health care. Let's get focused on delivering the product, please. And these ancillary conversations are important, but they are ancillary. Thank you. Anything else? Do we have anybody who'd like to speak on this item?
I do have one request on Zoom.
Let's go ahead and take that speaker.
Our first speaker is Paul Soto. You'll have 2 minutes to speak. Please go ahead.
Yes, Paul Soto from the Horseshoe. I agree with you. Supervisor Simitian. People need the health care. They really do. To become viable citizens in the community, a healthcare clinic is fundamental in order to maintain the viability and the health and the vibrancy of the people living in that community. However, when it comes to actually putting action behind that, there is always a deference to the more wealthier and affluent areas, and the Mexican gets the shaft every time, without fail. So we can't continue doing that. And now that's one point. Number two is that it troubles me that there are very well-educated citizens in our community that know that De Anza was a colonizer. You see, when De Anza got here, then they were able to like really commandeer the area and institute the mission systems in Northern California. They had already started down south. And so we know his history, but we create these fairy tales that make us feel good. It romanticizes something very tragic, very inhumane that happened to my people. I'm a direct descendant of Mission San Diego de la Cala. So it troubles me, though, that it has to come from certain communities in order to challenge that and change the name of De Anza. And it doesn't come from my government. There's no challenge on that. So if we're going to talk about racial equity and we're going to talk about clinics, I would also like to start talking about getting East Valley. We need to talk about that in this budget year. In this budget year, we need to talk about what and find out what that cost is going to be.
That concludes public comment.
Thank you very much. Supervisor Lee, can we get a motion to receive the report, please?
So moved.
I'll second.
Vice Chairperson Lee?
Aye.
Chairperson Simidian?
Aye. Motion carries unanimously. Thank you. We'll see you on the 27th. Thank you. Takes us to item number 11, mental health access for the West Valley. Who'd like to begin?
Good afternoon. Chair Smitty and Vice Chair Lee, Michelle De La Calle, I'm the Director of this Office of System Integration and Transformation for the health system. On Zoom, we have Don Taylor, the CEO from Pacific Clinics, and Laura Rosas is also here in the chambers with us. From our last report, we've had joint meetings between VHP and Pacific Clinics to ensure a sustainable program and services in the Los Gatos site. And there's a contract proposal in negotiation between Pacific Clinics and VHP. And we're following up. We have a follow-up meetings in the works to be scheduled right now on the recent proposal received. In response to the connection with Cassie, my team in OSID has been in connection with Cassie and the leadership team there regarding CalAIM opportunities and collaborative opportunities with especially around the children and youth population for ECM and community sports. And from behavioral health, Zelia, who works on school-based services, has also been in contact, and a meeting was rescheduled after it had to be canceled with the Cassie leadership, and that's in the works of being rescheduled as well. With that, we're here to answer any questions you might have.
Thank you very much. The only thing I have, Supervisor Lee and Mr. Nakai, is to ask if we could, I think the next update comes back to this committee in April, if I remember correctly. I do think it would be helpful to have a timeline and to see if we could get some of these items placed on a timeline in April, just so we know that we're going to have a deliberate march toward a successful outcome. Supervisor Lee?
So moved.
So we have a motion by Lee and a second by Simidian with a motion to receive the report and direction to staff to please come back at our April meeting with a timeline for the various activities that are described. Does that work?
That works.
Okay. Mr. Lorenz?
Yes, sir.
Okay. Thank you very much. Call the roll. We have no speakers, yes?
Correct. No speakers on this item.
Call the roll, please.
Vice Chairperson Lee?
Aye.
Chairperson Simidian?
Aye.
Thank you.
Thank you. Motion carries unanimously. Thanks very much. That takes us to item number 12. Medi-Cal, eligibility, redetermination, and community outreach.
Good afternoon. I'm Brian Darrow with the County Executive's Office. This is our monthly cross-departmental report regarding Medi-Cal renewal efforts. We have Vinod Sharma and Michelle De La Calle from the health system here at the dais, and then our DEBS director, Angela Shing, is available on Zoom.
Welcome to you all. Ms. Shing, welcome virtually.
We will be brief. I did, though, just want to take this moment to highlight one piece of really good news. This has been alluded to earlier, but since this is the first time we've had a chance to present in the new year, I wanted to highlight that on January 1st, as the committee knows well, the Medi-Cal program in California did expand, allowing all income-eligible individuals ages 26 to 49 to qualify for full-scope Medi-Cal, regardless of immigration status. So this was the last population that had been left out of the Medi-Cal program based on documentation status. So January 1st was a very good day. And in many ways, it was a culmination of efforts that started right here in Santa Clara County. In 2000, as the committee chair knows well, because I believe he was on the board in 2000, in 2000, the Board of Supervisors made the wise decision to invest tobacco settlement money into the Children's Health Initiative program. And that program made Santa Clara County the first county in the nation to offer health insurance to any child in a family earning up to 300% of the federal poverty level, regardless of immigration status. And that program was so successful that it was replicated in 30 counties. And then a little bit later, in 2016, the state kind of finally followed suit and expanded the Medi-Cal program to all children, regardless of immigration status, that are income eligible. They later followed in 2020, expanding to 19 to 25-year-olds. In 2022, we saw that expand to 50 and older population. And then just this January, we finally filled that final gap of 26 to 49-year-olds. And so I wanted to bring that up. Well, actually, one other point I wanted to make is that due to the efforts of a number of folks here at the dais and in our health system and the Social Services Agency and community partners, there was a big push to sign folks up for emergency Medi-Cal, also known as restricted scope Medi-Cal, ahead of the transition. And so what that did was that on day one, our Social Services Agency was able to convert 36,548 individuals in our county to full scope Medi-Cal benefits. So these community members now have access through Medi-Cal to primary care, specialty care, prescription medications, and many other benefits. And so again, I really just wanted to bring that history up because in part it's a credit to the leadership of this county, Supervisor Simitian and other folks who were on the board back in 2000 who made that decision. It's also the subsequent boards who created programs like the PCAP program, the Healthy Workers program, that really tried to fill gaps to the extent that we could, coverage gaps. And so this is an important day, and it's also just a reminder of how local policy change can really be a proving ground. It can affect the lives positively of local community members, but it also can be replicated, sort of a trickle-up approach. And in this case, that really benefited actually hundreds of thousands of folks, literally, as we've seen the expansion. So I thought it was a day to highlight that. And in terms of Medi-Cal renewals, which of course is the main subject of this presentation, the trend does continue to be in line with our pre-pandemic levels, or actually slightly better in some months. And so that has been good news so far. We continue to watch the data closely, and obviously Angela Shing can answer any specific questions about those numbers. But with that, we're here to answer any questions.
Thank you very much. I have a historical footnote I'll offer in a minute, but first, on to more substantive matters. Supervisor Lee, comments or questions?
Yes, so looking at the report, well, first of all, thanks for the very comprehensive report. And one area I would like to get more clarification is looking at the disenrollment dates from November 2023 and the reduced the number of patients requiring contact by 82%, going from 8396 to 1475. These are really huge number changes, right? So can you help explain the methodology, how to reduce these numbers on enrollees requiring the follow-up?
Good afternoon.
Good afternoon.
Supervisor Lee. This is Vinod Sharma with the Health and Hospital System. Can you hear me?
Yes, I can hear you just fine.
That 82% decline is basically we allow the processes to take itself. A lot of effort was going on in outreach to people, and we didn't want to add our team to also do that, so duplicate the effort. Within 60 days of the 90-day period, when we started, we realized that a majority of those cases have already been resolved. So we didn't need to concentrate on those. So this basically allows us to use our resources effectively and make a better impact.
Good. And I think that's all the questions I have for today. Thank you very much.
Let me give you one piece
Sure,
of
please.
good information. Each month, we were losing about 1% of the membership to the redetermination as people either moved out of the system or not eligible anymore because they got jobs and coverage through there. The expansion program for the 26 through 50 just started on January 1. I don't know the effect of that, but we just got the numbers for February, up to date. We have added 12,000 members last month, lost 4,000, so the net effect is 8,000 new members. Starting from June, when we started tracking it, we had lost about 6% membership. That cumulative loss is, as of today, 1.3%. This may not continue like that, but this is a good, encouraging news I thought I should share with you.
Great. Thank you very much.
Thank you. The historical footnote is this. The program to ensure every kid in the county was initially brought to us by community members who had approached the city of San Jose back in the year 2000. And for whatever reason, they couldn't get to yes with the city of San Jose and the mayor's office at the time. So they reached out to members of the board to see if we were open to leading on the issue. Got a good response from whoever they talked to at the time, and of course, Brown Act being Brown Act, you know, most of us didn't know who was talking to whom. But I remember very well the conversation that I had on the phone upstairs and then here in the chambers, because I said, well, if we're going to do this, it really should be a countywide program. And I understand that the greatest level of need will be in San Jose as compared or contrasted with some of the other suburban communities, the smaller communities. But I made then, I just wanted you to know I've been on this topic for a while, I made then the argument that I continue to make, which is that if you are a person of limited means, that can be even tougher in a more prosperous community where there is not an abundance of services readily available and where too often you are invisible. And we had the discussion right here in the board chambers and made the decision in real time that the program would be not limited to the single largest city and the city with undeniably the greatest need, but to qualifying kids in every single one of the 15 cities and towns in this county. And we continue to have that conversation. It is sometimes necessary, in my view, to elevate that point again and again, because I think it's too easy to overlook the fact that there are folks in the other 14 cities and towns who are hanging on for dear life, trying to make their way in a very high-cost county. And if it was tough then, it's even tougher now, in my view. So with that historical footnote, can we double-check nobody to speak, or there are?
No speakers on this item.
Supervisor Lee, motion to receive the report.
So moved.
Motion by Lee, second by Simidian. Anything else before we let you get away? Because we're about to call the roll. Call the roll, Madam Clerk.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Motion carries. Thank you very much, and thanks for making sure that people who need the help get the help. Appreciate it. And that takes us to item 13. And that is our, what I sometimes call our catch-all item. We have items 13A through G. And item 13A is to hear from our Chief Executive Officer at the Santa Clara Valley Healthcare System, Mr. Lorenz.
Thank you, Chair Simidian. Obviously, you have our written report. I did want to add that yesterday, February 13th, the county received notice that Regional Medical Center would be terminating their agreement with the county around their designation for trauma, STEMI, and stroke. As I understand it, because your health system is going to be impacted quite significantly by this change, with respect to stroke, my understanding is they're moving from comprehensive to primary, so they are lowering the level of care, but they will provide some level of stroke service to the community. With that being said, your team, the health system, has been meeting to discuss what those implications would mean relative to not only the community, but really to your health system. And as you well know, Valley Medical Center is a level 1 trauma center. Today, annually we see around 4,000 trauma cases at your hospital. My understanding is that such a change in the trauma system would clearly impact the level of service that we can provide to the community. So we are looking at that. Fortunately, I will say that we have O'Connor Hospital, and as a system, we will be looking at ways in which we can leverage the system to ensure that critical services for the community, primarily in that area, can be sustained at some level. But there is a lot more to be understood as we move forward in the coming months.
Thank you very much. Supervisor Lee, any other questions or comments before we go on to 13B?
Yes, I read the letter from the CEO explaining one of the rationale for closing the trauma center. One of which was mentioned is the fact that they said, oh, there'll be another trauma center being stood up. But when I looked into it, it looks like that's not one from anywhere near Regional Medical Center. It's actually up in Alameda County and Washington Hospital, and I tried to do distance measurement. It takes about 25 minutes to get from regional to this hospital versus to VMC, which is only about 16 minutes. So with that comparison, it really showed that argument didn't fly with me. And basically, is if folks need help that's being served by Regional Medical Center right now for trauma care, they will be going to VMC as we speak. Is that a correct assumption?
Well, I will defer to Ms. Jackie Lowther regarding the impact to the EMS system. My understanding is, as you've stated, that the only other hospital that is looking for trauma designation is Washington Hospital, which is in Fremont, which is part of Alameda County, and does not impact the catchment area for Santa Clara County EMS.
Nope.
So what we are anticipating as a health system, county health system, is for that burden to fall upon us because we are the only other level 1 trauma hospital or trauma hospital adjacent to that community in Santa Clara County.
Remind me again, the level 1 trauma center besides VMC right now in our county, where else have that level of service in our system?
So the only other trauma system level 1 is Stanford in Santa Clara County. And those would be the only 2 trauma hospitals left in Santa Clara County, both level 1 trauma centers.
And South County, currently, like St. Louis, for example, is a different level, right?
So St. Louis Hospital is not a trauma hospital, trauma center. As you well know, we are looking for St. Louis to become either a level 3 or level 4 trauma hospital as part of the EMS system.
Right.
But that is still in the works.
Right.
And Supervisor, there is a very significant difference between a level 1, level 2, and that of a level 3.
Right.
A really critical patient should be going to either a level 1 or level 2.
Right. So right now, anybody who in South County basically needs a helicopter to fly up to VMC to receive that level 1 care.
Yeah, depending on severity, but really most South County residents that require trauma level care either come to Valley or they go to regional presently.
Right, correct. Thank you. I mean, this is certainly a very concerning letter, development, which I certainly want to make sure that we are getting ready to find ways to meet that need, because even O'Connor, where it's located right now, would not be as convenient, of course, to many of the residents in that area near regional, because the population there certainly has been growing quite significantly. So I'm extremely concerned about this development and how we can continue to make use of that facility or some of the equipment and whatnot. So anyways, I just want to voice my significant concern on this, and I'm sure that's what you and many of your colleagues is worried about too, as well. So please keep us posted. Thank you.
Thank you.
Thank you very much. And that takes us to 13B, which is any additional comment from the public health officer. Dr.
Nothing
Redmond?
further. Thank you.
Okay. 13C, behavioral health.
Nothing further.
Supervisor Lee, I'm looking to you to lean in if you have additional questions. Thank you. And 13D, custody health.
Happy to answer any questions. You have the report in front of you.
Supervisor Lee, I see you leaning in.
Yes, I've heard some latest statistics that there was some usage of our Narcan kits recently in our system there. Just want to get some updates from you, how severe that was, and any type of results of that. How many folks were being used upon, and et cetera.
We have it, as you know, we have it in our jails and available to our teams, and we use it, unfortunately, periodically. And we did have an event a couple of weeks ago that I'm happy to report off agenda if you'd like, with additional details.
Please, yeah, thank you. I really appreciate it. Thank you.
Thank you. And I saw the confused looks as I confused you all by saying the wrong letter with the wrong number. So let's go back to what was 13D, still is 13D, and that is the report from Valley Health Plan. We just heard, for the record, 13E, the report from Custody Health. Forgive the confusion on my part.
Thank you, Chair Simidian. You
lean-
have our report, and I'm happy to answer any questions that you may have.
All right. Supervisor Lee, anything else
Nope.
on Valley Health Plan?
Thank you.
All right, after all that, there we are. And that takes us then to 13F, Emergency Medical Services.
Good
EMS.
afternoon, Supervisor Simidian, Supervisor Lee. Happy Valentine's Day and Happy Heart Month. Couple of things. The missing responses from AMR are down to 563 as of 7 o'clock this morning, as well as I wanted to point out the improvements in their deployment has improved significantly over the last couple of months, including for January, topping the 850 target towards 900. And we are really looking forward. Their hiring has gone very well. Their Earn to Learn program is really producing great candidates that are currently enrolled and helping staff that deployment. As far as the news that we received yesterday from regional, I do want you to know that according to the Health and Safety Code, that the EMS agency is working on a impact assessment, currently gathering data so that we know how it will impact the entire county. There is a public component to that, so that we will be meeting with constituents, stakeholders, to look at, because it isn't just trauma, it will be STEMI or heart attacks as well as stroke. So we will be meeting with county executives and leadership around. Starting tomorrow, we're meeting with stroke STEMI, today with the trauma team, to start working through day by day. I have communication with state EMS authority, so working to get this impact And so we will keep you informed every step of the way. Any questions that?
No, thank you for clarifying that. And I thank Paul for explaining that for stroke and heart attack, that might be something that regional medical might still be able to serve. Is that what we're hoping? No, after the trauma center is being changed after 180 days, or they won't be? Because we know the reason why this is such a big deal is because certainly every minute counts. If we have to travel another 15 minutes from point A to point B because of the fact that RMC is no longer available, or even 20 odd minutes to Washington, that is definitely an issue of life and death for a stroke or heart attack patient. So I just wanted to make sure that what type of services would that something still be handled by RMC or no in the future?
Heart attacks, they will be a regular ER. They have agreed to stay primary stroke center. That is dropping them from the current comprehensive stroke center that they are today. And that leaves all of our comprehensive or thrombectomy capable centers on the west side of town, which is Kaiser Santa Clara, El Camino, Good Samaritan, Stanford. So we are working on transfer agreements, everything that we have, every policy. So we will be working diligently over the next few days. There's a very short timeline to be working through this. They gave us the 180-day sort of, that's what they have by contract to give us notice. But as I said, we will keep you notified each and every step, as well as all of our partners, which is every hospital that's impacted.
So is it possible, I would like to look, I'm a very visual type of guy, to see the locations of all these places you mentioned, to see with this change, how the impact would be in terms of the patients might have to go from where they are now in RMC to those facilities that you mentioned throughout the county, like the west side and whatnot, in order to be able to truly understand the impact of how they'll be impacted in terms of the number of minutes will be added to commute, for example.
Yes, sir.
Yeah, so if we could get like a map to show the different locations and how these different conditions will be affected, I'd certainly appreciate it.
Yes, sir. We'll be sending you official notification with those impact details.
Great. Thank you so much, Ms. Loader. Thank you, Paul.
Thank you, and I have no questions at this time, but Ms. Lather, I know you know from our prior conversations in this committee my interest in the stroke protocols and the comprehensive centers, and that's before we even get to the challenges of having limited access to trauma centers at their acute level. Thank you. All right, that takes us to item 13G, the report relating to the federal health policy and budget landscape. Mr. Margolin, how are you? I always worry that we have you at the kids' table down there, but
So let me begin by saying that I think Mr. Campos was going to join by Zoom and had some initial comments he wanted to make.
Sure. If I may,
Yes.
Chair Simitian, Vice Chair Leet, can you hear me okay?
Yes.
Loud and clear.
Well, thank you. My apologies for not being there in person. I'm actually here in Sacramento, where we have a number of meetings with legislators on various matters involving the county. I'm just going to quickly turn it over to Mr. Margolin. A lot has been happening in the healthcare area, and I think that he has been keeping track as well as anyone can, given the many developments, and we do want to provide at some point more updates on the state level. So you will be getting something from us on that front. So Mr. Margolin, I'll turn it back to you.
All right. Thank you very much. So let me start with an update on the extended federal budget debate. The latest set of continuing resolutions, CRs, are set to expire on March 1 and March 8th. This is part of the so-called laddering strategy that Speaker Johnson developed last year, the idea of breaking the 12 appropriation bills into two groups, 4 bills initially, 8 bills later on. The health issues that we are tracking and most concerned about come up in the second batch on March 8th. That's where the 2-year termination of the scheduled dish cuts will be considered, and various health program extenders, such as the extension of funding for community health centers. They're all part of that March 8th package. Unlike prior budget negotiations in recent years, where there's been this distinct threat of a government shutdown, nobody appears to want a government shutdown this time. We're in the middle of an election season. The appropriators on both the House and the Senate side are actually going back and forth. There are still big differences in how much money the House wants to spend versus what the Senate wants to spend. But the Republican appropriators understand that all of these policy riders that were highly controversial that they passed last year, such as a ban on funding for gender-affirming care, they included that in all 7 appropriations bills. There are other measures of that sort. They understand that the Democrats won't accept that language, and it's likely all of that gets dropped. There'll be a battle, and is a battle right now, over funding levels, because again, the House is at a much lower level. But it's likely there'll be a deal. But here's the wrinkle in all this. A deal would involve a bipartisan vote. There's no way that with this razor-thin margin in the House that Speaker Johnson can pass this, as he is wont to do, on a party line, strictly party line basis. So he'll have to rely upon Democrats. Unlike before, there's no immediate jeopardy to his speakership, we think, at this time. The Republicans who ousted Speaker McCarthy don't want to necessarily go through that again in the middle of an election cycle. So while there's no, so it's unlikely that he'll be challenged, but he does have this angry faction that isn't going to be happy with the spending levels he'll ultimately be forced to approve. So that's how all this stands today, but there's one intervening event that will occur between now and March, early March, that will affect the environment in the Congress, the environment in the House, and could impact the budget negotiations in a significant way, and that is this supplemental foreign aid package that was passed by the Senate. It's $95 billion for Ukraine, Israel, Taiwan, and other purposes. 22 Republican senators joined the Democrats in passing it out of the Senate. What will Speaker Johnson do with that package? Because it has to be resolved rather quickly. No one knows. One of the tendencies Speaker Johnson has developed here is to not really indicate to many people within even his own caucus as to what his plan or intention is before he actually executes. He's somewhat secretive in that regard. Slow to develop, actually, a plan. But there are certain things we know. He's not going to pass the Senate package as is. Can't do that, won't do that for a range of reasons. But he could decide to take it up in some other form. He could decide to break it up into separate pieces. He could keep it together or break it up and add various amendments involving the border and other issues, amendments that the Senate would not want to accept, but that leads to a House-Senate conference committee where these issues get worked out. But if he doesn't take an action quickly, and there's a delay, which is what his inclination seems to be or has been in the past, then there are other options that could be pursued that could be quite explosive in the House and could produce a great deal of partisan acrimony. There's a discharge petition that's ripe that was filed several months ago. It will have to be adjusted somewhat to deal with this issue, but if the discharge petition attracts Republican signers, a big if, that's an option. And there's also something called the previous question, moving the previous question, where if you reject this parliamentary motion, it's a rather arcane House rule, then the minority party has control of the House floor for an hour to do whatever amendments they want to do. Rejecting the previous question requires, once again, Republican votes. Republicans either have to sign a discharge petition or join with Democrats in rejecting the previous question. Either maneuver is quite a hostile act to the Republican leadership. Will put those Republican members in some trouble with their own leadership. But the urgency of aid for Ukraine, Israel, is such that there are a number of Republican members who said this has to happen one way or the other. Facing that, Speaker Johnson may in fact move quickly with some measure. So we don't know what's going to happen here, but you can see the potential for acrimony, a rebellion within the House Republican ranks against the Speaker. Unclear what will happen. Lots of activity over the next few weeks. It will color quite significantly what happens with the budget debate. The other issue I want to touch on briefly is turnover within the leadership of the Energy and Commerce Committee on health issues that impact the county. We just heard a couple of days ago that Congresswoman McMorris Rogers, the chair of the committee, is retiring, not going to run again. This committee is very powerful. It's the Committee of Jurisdiction for the Medicaid program. McMorris Rogers worked on a bipartisan basis with Congressman Pallone to produce the lower cost, more transparency bill that included a deferral of the dish cuts. That's a big change. And on top of that, we have Congresswoman Eshu's retirement, leader on health on the Commerce Committee. She's leaving. And then Congressman Tony Cardenas of Los Angeles, a longtime member of the Commerce Committee and a member of that subcommittee, also announced his retirement. So new leaders will emerge next year. And the two I want to just highlight briefly here are Congresswoman Doris Matsui of Sacramento, who's played a key role on that committee for some time. She's not currently on health, but could return. And then Congressman Ruiz is on the subcommittee on health. He's an emergency room physician, he has a master's in public health, highly knowledgeable. He may emerge as a leader on healthcare in the coming Congress. I wanted to flag this turnover in Commerce Committee leadership. I'll give you, again, as I just did, a brief report on this uncertain budget negotiation. Happy to respond to questions.
Forgive me, I was... You mentioned Congressman Pallone. He's not part of the leadership change that you're anticipating.
He's not, but I was mentioning him in the context that he and Congresswoman McMorris Rogers worked together relatively well on health issues. And I was making the point that her departure, this is an area where there was some bipartisan cooperation, at least on Medicaid and health, and her departure makes that future relationship very uncertain. No, Congressman Pallone is planning to continue.
So on these health matters, among the takeaways is some key players on the health subcommittee of Energy and Commerce departing.
Yes.
And the chair of the overall committee is no longer going to have the same partner to work with as they try to guide legislation through the committee.
Well, he's the ranking member right now.
Excuse me, the ranking member.
Who could become the chair next year, depending upon the election.
I may have been projecting.
You may have
Mr.
been
Vargel,
projecting
so
correctly.
There you go.
That's correct.
Thank you. My apologies. All right.
That's all right.
Thank you. Supervisor Lee, any other questions, comments?
I find fascinating on that one regarding the discharge and those couple of options. So those are the unusual maneuver where we have a Senate that has passed a bipartisan bill that the Speaker is not willing to put to the floor. And this is a way for members to basically force that issue to be put on the floor to be voted upon.
Correct.
Am I correct? Yeah.
That's
Okay.
correct. And again, it's tried occasionally. It almost always fails. So this would take extraordinary circumstances for it to succeed. But these circumstances may be extraordinary enough.
Well, and also the margin's never been this narrow.
Yes.
By the
Yes.
majority. I mean,
Incredible.
with the vote yesterday on the New York 6,
Yes.
replacing our infamous former Congressman Santos' seat with a Democrat, I think that the difference is not 2 votes or two.
It's a 3-vote margin.
3-4 margin, right?
margin, yes.
So as narrow as it is, I think it seems like given the importance of these foreign aid, folks are literally dying for freedom in Ukraine. I think they probably will have enough Republican votes to might do something like that in order to advance these legislation.
And the threat of that may lead Speaker Johnson to say, I don't want that to happen, and therefore I'm going to put together some kind of package. It won't be with the Senate pass, but we'll go to conference committee and negotiate it out.
Right.
That's the other approach.
So in that case, that bill that passed by the Senate is absolutely not dead. It's absolutely
not dead. It
it's very
becomes a
live.
Senate position in a conference committee.
Right. Good. Okay. Thank you very much. This was very helpful.
You're welcome.
All right, thank you. Do we have any speakers on item 13? Let me just check with the clerk.
No request to speak.
Then, if there are no other comments or questions, we could say thank you and ask for a motion to simply receive the various reports.
So moved.
Motion by Lee, second by Semidian. Please call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Semidian.
Aye. Motion carries unanimously. And now, folks, this is a little unusual, as I said, but we are going to simply roll into the next item as part of our joint meeting, and that is the portion of our agenda that is really set aside for Federal Affairs Advocacy Task Force, where we have just a couple of items where we wanted to make sure we got to these things sooner rather than later and did not lose them by virtue of a meeting which otherwise might have been canceled for timeliness reasons. All right, item number 14, County Council.
Yes, good afternoon, Douglas Press. Chairperson Semidian and Vice Chairperson Lee, I just wanted to, as part of the County Council report, address two matters, or groups of matters, I should say. One is the what we're calling the mifepristone cases, and the other is a case, or actually a group of cases that we talked about last time about Chevron deference, because we've had a recent Supreme Court argument on those cases. So let me open with the mifepristone cases, and just for everyone's recollection, these are for medication abortions. Currently, there is a two-drug regime, mifepristone and misoprostol. And in April of last year, a district court in Texas enjoined the FDA's original approval of mifepristone that was originally approved back in the year 2000, as well as enjoining a series of essentially relaxation of various dispensing attributes, conditions that have occurred over the years. So the district court stayed its order, but had it not been stayed, fundamentally that would have changed medication abortion and reproductive care almost overnight. That was ultimately taken all the way up to the U.S. Supreme Court, and in late April of last year, the United States Supreme Court issued a stay on the district court's order until that entire matter had been heard, if at all, by the Supreme Court, ultimately on the merits in a non-emergency fashion. And so, in essence, status quo until the Supreme Court finally decides and hears the issue, if it was ultimately asked to decide and hear the issue. So in that regard, the case made its normal way through the appellate system. So the district court decision was then appealed to the Fifth Circuit Court of Appeals. What the Fifth Circuit said is it's reversing the district court's order enjoining the FDA approval of mifepristone from the year 2000, meaning, at least from the Fifth Circuit's perspective, the FDA approval of mifepristone as a drug to be used in medication abortions and also off-label, that was okay. But the Fifth Circuit did uphold the district court in enjoining these other relaxation of dispensing sort of changes that had occurred over the years. That has all now been appealed to the U.S. Supreme Court. And at this board's direction, we have partnered with the City of New York, as well as being joined by a number of other jurisdictions around the nation that also operate large public hospital systems. I'll just read them here. County of Los Angeles, City and County of San Francisco, King County up in the state of Washington, as well as Cook County, Illinois. And we filed an amicus brief in support of the FDA in the United States Supreme Court on the merits. We also participated earlier on, but we have weighed in. The Supreme Court is scheduled to hear oral argument on March 26th of this year. So I will be able to report at the April meeting how oral argument went, and then we'll have to see. Certainly, we will have a decision most likely by the end of June, the end of the Supreme Court's term or thereabouts.
And Mr. Press, forgive the interruption. You indicated our county's role again is what in the litigation?
As what's called a friend of the court brief, an amicus brief, and I will talk about that in a minute with regard to the Chevron deference cases. But this is a way for non-parties to a particular litigation to, with the court's permission, to file briefing and to further advise and inform the court about the larger context and impacts of the various decisions if they were to go one way or the other.
And you mentioned the relationship with a number of other jurisdictions who were choosing to weigh in this same way, each with their own individual brief or with a common brief?
So we partnered very closely with the City of New York, and then with that product, LA, San Francisco, King County, and Cook County joined on to that.
So there is one
Yes.
group work product?
Yes.
Okay.
And there's many, for a lot of these cases in the U.S. Supreme Court, as you well know, there's many, many amicus briefs filed on both sides of the issue.
Got it.
But the one takeaway that I want to just keep reminding folks of, as we do, as we have been, frankly, for almost the past year now, is because of the Supreme Court's stay order that issued last April, I believe it was April 21st of last year, it is status quo as far as use of mifepristone as it has been, before the lawsuit was filed, before any orders issued from any court. Status quo, still lawful, still legal, useful everywhere in the United States.
But that status quo could be either sustained or turned upside down, depending on what the court does following the March 26th arguments.
That is correct.
Thank you. All right. And moving on?
Questions?
Not
Yeah.
on that, not
Okay,
on that
so
piece. Thank you.
The second one I wanted to just raise was something we had talked about last time. There's two other cases, and these were both heard in the United States Supreme Court on January 17th of this year. And this is regarding Chevron deference. The two cases are called Loper Bright Enterprises versus Raimondo and Relentless Inc. versus Department of Commerce. What is Chevron deference? As a reminder, Chevron, not the oil company, but the lawsuit, the case, it's called Chevron versus Natural Resources Defense Council. It's a 1984 case, often described as the most highly analyzed administrative law case in the Supreme Court's history. It held, in essence, that if there is some type of gap or ambiguity in a statute, and Congress has charged a federal agency with implementing that statute, then when that federal agency speaks to those gaps or ambiguities, typically by way of regulation, not always, but typically, then the courts are instructed to really defer to the agency interpretation to fill in that gap. This used to be a widely supported and respected doctrine, this Chevron deference, but it has fallen out of favor in the last, frankly, decade or so. And in fact, during the oral argument on these cases just last January 17th, a number of the litigants noted that, frankly, Chevron deference hadn't been even relied on by the United States Supreme Court for 6 years. The bottom line is this. The Supreme Court argument for both of these cases, which occurred one after the other in January, I think made it pretty clear that the United States Supreme Court probably will overrule Chevron to some degree. I do think, though, that most members of the court were comfortable with recognizing some degree of deference to administrative agency interpretation of these gaps, or silence, if you will, even in statutes. So I'm not entirely convinced, and certainly I think some of the Supreme Court justices would echo this, that it's not entirely clear what the impact, the practical impact would be if Chevron were actually to be overruled. So that, I'm sure, will be the subject of an enormous amount of debate in administrative law circles. And further still, I don't know if it's going to have a great deal of impact in California, because we, under California law, have something that I think is even less deferential than Chevron in our own California law, and that hasn't really been an impediment in our California court system. One thing I wanted to point out, though, and if anyone has any spare time, these were brilliantly argued cases, both sides for and against the Chevron deference rule. The Solicitor General and a couple of private sector attorneys, absolutely stunning oral argument. And what was really fascinating is that both sides, both advocates on both sides, and many Supreme Court justices often referred to arguments being made in the amicus briefing for these cases, really underscoring the fundamental point that I would just like you to have all sort of as today's takeaway from my little presentation, which is that amicus briefs matter. They really do. You think, well, geez, there's 20, 30 different amicus briefs, per Supreme Court case. The justices do read them. They are often brought up during oral argument. They do come up and they are cited in the opinions. So when you look at our grid and you see how many cases the board has authorized and or directed the county to weigh in on by way of amicus brief, that is not idle work. That is vital work for the county and for the causes that we care about.
Thank you very much. Let me see, this item is 14. Do we have speakers on this item, Madam Clerk?
We do not.
Supervisor Lee, comments or questions, or a motion to receive the report?
Yes, very comprehensive report. Thank you very much. And no further questions, and ready to move forward to receive the report. Thank you.
Thank you. Motion by Lee, second by Simidian. Before you call the roll, I'll just say, Ms. Press, I, of course, do want to make sure that, without in any way diminishing the Chevron deference issues, I do want to make sure that the committees, plural, Health Committee in particular, are kept apprised of the status of the mifepristone cases, please.
Absolutely.
Thank you. Call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Motion carries unanimously. That takes us to item 15, which is the CEO report from Mr. Campos and Prime Policy.
Yes, Chair Simidian, Vice Chair Lee, David Campos again here from Sacramento. And we're not going to have Prime Policy on today, so I'm just going to give a very brief oral update on where things are with the issue of whether or not the county can continue to follow its policy of not selling leaded aviation fuel in the county. I want to note that in the audience is Deputy County Counsel Jarrett Yan, who is here to provide any discussion of any legal issue that arises. But following up on the presentation from Mr. Margolin, it is in the context of everything that's been happening in Congress with a Republican-controlled House of Representatives and a Senate that is controlled by a vote or so by the Democratic majority, that this issue of leaded, unleaded aviation fuel has played out. As you may be aware, the Republican majority and some in the aviation industry have used the bill, the FAA reauthorization bill that happens every 5 years, as a way of inserting language that essentially would prohibit jurisdictions like Santa Clara County from banning the sale of leaded aviation fuel. What came out of the House of Representatives, essentially, if it passes, we believe in our interpretation, would prohibit the county from continuing to do what it has chosen to do, which is the precedented vote taken by this board to not sell leaded aviation fuel at its airports. I want to note that tremendous help that we have received on this front from our delegation, including Congresswoman Lofgren, Congressman Khanna, and others who have done everything they possibly could to change the outcome in the House of Representatives. But given the fact that you have a Republican majority, what came out of the House made it so that if it remained, we would not be able to continue with our policy. Therefore, our focus has been in the U.S. Senate, and that's where we have been working closely with Senator Alex Padilla and his staff, and they've done a tremendous job working with us to influence what came out of the Senate, and specifically what came out of the Commerce Committee, which has jurisdiction over this issue. And where things are right now is that we have seen the Commerce Committee vote on a version of the bill that, though not perfect, from our perspective, would actually allow us to continue to do what we're doing. It would essentially allow airports that took the action when we took it, when the county board of supervisors took it, to not sell leaded avgas. And that came out of committee. And then the question is, what happens next? And that's a question mark. Not clear exactly if there will be a floor vote at the Senate and when that will happen. But one of the things to consider is that we have had a number of extensions or continuing resolutions on the FAA bill. The last resolution, continuing resolution, actually expires in early March. And so what we suspect is likely to happen is that there will be yet another extension, how long not clear, so that both the Senate and the House of Representatives have an opportunity to work this out. So far, we see perhaps some change in the right direction with the Senate version of the bill. We're going to continue to track it and are cautiously optimistic that in the end, what we have in place will hold. But again, it's hard to predict at this point. And again, we're grateful to our delegation that has been really instrumental in making sure that the right of jurisdictions like Santa Clara to decide for themselves what is right for their communities on this issue, that holds. So happy to take any questions from you at this point.
Mr. Campos, forgive me, but I got lost a little along that long and winding and tortuous path. So let me just ask a couple quick questions.
Yes, sir.
At present, the live vehicle is a product of the conference committee. Is that correct? The reauthorization bill?
So at present, we have two versions of the bill, a Senate version and a House version that is likely to go to conference.
Okay.
And when that will happen is unclear at this point.
So there is no conference product as of this date?
Exactly.
Thank you. And then, as I understood it, the Senate version is more favorable to the county's position?
That's correct.
And that's because the Senate version allows what?
It essentially, and I'm happy to turn it to Mr. Yan to explain, but you have an amendment that deals with Section 620 of that bill, which is the Fisher-Sullivan Amendment, that essentially allows jurisdictions that took action around 2022, which is after we took action. So anyone that took action before that date in 2022, for that action to hold with respect to leaded aviation fuel. So
let me interrupt. I apologize. And is it Mr. Yan? Y-A-N?
Yes. Yes.
Thank you, Mr. Yan. Mr. Yan, I'm determined that I'm going to get out of this meeting understanding clearly what the state of play is, notwithstanding the fact that it is a long and winding and tortuous path. The Senate version of the bill, it sounds to me like it has what I would colloquially refer to as a grandfathering clause that essentially says if you took action to prohibit leaded avgas either around or prior to 2022, your regulation can stand. Do I have that right?
Correct.
Okay. And what is that bill's posture language requirement with respect to anyone who attempts to make such an effort after 2022. So let's say, an airport, general aviation airport in Alameda County or Contra Costa County attempted to do the same thing sometime in 2026. What would the Senate bill say about that?
So there's a bit of nuance here in the sense that the House
And
bill.
excuse the interruption. Is a bit of nuance code for it's not all that clear?
There's a lot of detail. There is a lot of detail and some clarity.
I'm sorry for the interruption. Please proceed. Go ahead.
So unlike the House bill, which imposes a strict mandate to continue making available leaded avgas, what the Senate bill does is add a term to the grant assurances that airports agree to every time they accept a federal grant. So in order to be bound by these terms, you would need to have taken federal money after the passage of this bill. So that's one piece. And also one difference between the two bills and one reason that the Senate bill is less strict.
So not to put too fine a point on it, the Senate bill would effectively say to other jurisdictions and airports, if you want our money, you have to provide leaded avgas.
Correct.
Okay.
The Senate bill is also different in that it has a caveat. It has a sunset clause, effectively, that it only applies until 2030 or until the airport has an unleaded replacement fuel that is 100-octane replacement fuel that is available at the airport, to paraphrase a little bit.
Okay. And on the House side, where a bill has passed, as I understand it,
correct,
and is in the conference committee, and the issue is not yet resolved, the House bill, I heard you say, requires airports to provide leaded gas, but I thought there was a carve-out for Santa Clara County. Am I remembering that wrong? Entirely possible.
We've had discussions with committee staff. They put in some language that they've said they think exempts us. There's some back and forth about the actual effect of that language, so details and nuance. But I think that the Senate bill much more clearly does not apply to us because the Senate bill says only applies to airports that offered leaded avgas for sale in 2022. Whereas the House bill says if you sold it at any point past 2018, then you need to continue having it available.
Okay.
If I may, Chair Simitian, I think that there is a difference of opinion on the House bill. And again, that bill was made a lot better because our delegation pushed for the changes. But we would prefer that something that resembles the Senate version is what actually comes out of conference.
Thank you. And the timeline for something coming out of conference appears to be what?
Not clear. Possible sometime in March, but most likely after the current CR expires. I think it's March 8th. So we are likely to see another continuing resolution, essentially extending the timeline to vote on the FAA reauthorization. As Mr. Margolin said, there are a number of items that are before Congress, and even though FAA reauthorization is an important item, there are other matters that apparently will be more of a priority for the Congress.
And forgive me for asking you gentlemen about a district perspective on this. I'm sure you will recall that while we have two airports now, the South County San Martin Airport and the Reed Hillview Airport, at one point we had a third airport, that was the one in Palo Alto. Ultimately, Palo Alto acquired that and is now responsible for the Palo Alto General Aviation Airport. It sounds to me like under either of these scenarios, if that airport wanted to make the switch to unleaded aviation gas, they would be precluded from doing so. Did I understand the ins and outs and backs and forths as things now stand?
I believe that is most likely to be the case, Chair Simidian. I would defer to county council on that, but our understanding is that that is the likely outcome.
So it would again depend on which bill passes so if, for example, the Senate bill passes and Palo Alto accepts additional federal grants.
Forgive me, it's the caveat is they could do what they want as long as they don't ask for any money.
Assume under the Senate bill, yes. Under the
Thank
House
you.
bill, the rules
Thank
are a
you.
little bit different.
That was the caveat I was not bearing in mind. Thank you. That's helpful. And we had talked a little bit at the previous meeting about the additional issue of airplane noise being part and parcel of the discussion about the reauthorization. I believe in the House that Representatives Mullen and Panetta and Eshoo voted no on the reauthorization bill, and I don't know how much of that, I mean, I won't even speculate about am I remembering that part right? I won't speculate about their motives, although the airplane noise would further complicate the issue of leaded gas, I would imagine, for them and their districts.
Mr. Chair, you are correct about that, and in fact, I believe that was largely because what passed in the House did not address the issue of airport noise, and not clear that where the Senate version is on that point. The one thing that I would note is that the big sticking point on the whole bill is not airport noise or leaded unleaded avgas, but it's actually the issue of pilot training, which has been there's been a big difference of opinion between the Democratic majority and the Republicans on that issue, and that has been the sticking point that has kept the bill from moving forward as we understand it.
Yeah, I think Supervisor Lee, just to take the opportunity to lobby you a little bit on this issue. What has become abundantly clear to me in terms of the small p politics of the matter, Mr. Campos, is that the FAA's mandate, its charter, its reason for being, is the promotion of civilian aviation, and they will tell you that repeatedly. And what that means is that when you raise issues about noise, or even noise measurement, or avgas, their default position almost always is, that's interesting, but not really our issue. Our issue is making sure that we continue to promote the viability of civilian aviation, and caveats, conditions, or restrictions are not part of their mission as they see it and as they exercise it. So, excuse me, gentlemen. All right, well, thank you. I think that helps me at least clarify the state of things. Supervisor Lee, comments or questions on this item?
No, I think you've asked a lot of questions, being how difficult this one is, and I definitely don't have any further at this point. Thank you.
All right, thank you very much. Do we have speakers on this item, Madam Clerk?
We do not.
All right, then, here again, I believe the only requested action is a motion to receive the report. Supervisor Lee, are you prepared to offer such a motion?
So moved.
All right, I'm prepared to second. Do we have anyone else on the team here in chambers, in virtual land? Nope. All right, then let's call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Simidian?
Aye. Thank you very much. Thank you for the work as well as the report. And let me just confirm with the clerk, I believe that completes all of the items on our blended agenda today, yes?
It surely does.
Then without objection and hearing none, I will say thank you. We are adjourned. Appreciate it. Thank you.